Hello and welcome to today's King's Fund event on patient and user engagement in the delivery of virtual care. My name's David McGuire. I'm a senior analyst in the policy team at the King's Fund, and today I'm joined by a fantastic panel of experts from around the world of health and social care in digital technology. I'd like to thank our sponsor, South Central and West, an NHS support service that helps health and social care organisations deliver the best possible care to people. I should also note that we are recording this event ahead of time. We've accumulated a list of questions from you, the audience, during your registration process. We'd like you to submit even more questions via Slido. You should see a box to the right-hand side of the video, which is where you can submit your questions. Our speakers are watching live with you, and we'll be able to respond to questions directly there on Slido. We'll also be putting up some poll questions and word clouds to you. These are going to flash up at various points during the session, again in that same Slido box on the right-hand side of the video. You can also follow the conversation on Twitter using the hashtag KFOnline and take a look at some of our resources that we've linked to on this page. So what are we here to talk about today? Well, as you will have seen in the event description, 2020 was a huge year for advances in how digital technology were used within the health and social care sector. The sector had to respond to the pandemic with a completely different way of delivering services across health and social care, particularly in things like primary care and outpatient services in particular. But that happened at speed. And one of the things that we're quite interested here in this event is what the effect has been for patients and members of the public in being involved with those discussions, and how might we build that into future moves in the health and social care use of technology. As I say, I'm joined by a fantastic panel today, starting with Tara Donnelly, who is Chief Digital Officer at NHSX. Tara, please tell us a little bit about yourself and your role.
Thank you very much, David. Yes, I'm Tara Donnelly. I'm the Chief Digital Officer at NHSX, as David just introduced me, but I spent my career mainly in operational roles across the NHS. So I come to digital not as a technologist, but really as someone who can see its potential to help clinicians and patients in quite different ways. And to put in a nutshell what we do at NHSX is to digitise, connect and transform. So digitise services, connect them to support integration, and through these foundations really enable service transformation to deliver wholly new models of care, to empower people to take control of their own health and care, with much more of this being home-based, and importantly to be able to share results with their clinical teams. And this latter area is the focus of my small team within NHSX. And at the very start of the first wave, actually in March last year, we were approached by a clinician leading a really very large virtual ward in Hertfordshire to ask if was there any tech that could help them do that job. And they were obviously seeing increasing volumes of people with COVID. And there began a journey about using a pulse oximeter and an app to support now thousands of people at home. From that first site, we've now got 78 services using that model. And over recent months, we've been working in collaboration with all the regions in England to establish remote monitoring locally. These can be in care homes for people with long-term conditions, both physical and mental health, and also to support those very high-risk individuals with COVID with home monitoring. And we're really delighted with the progress within ICSs and regions, particularly given the other pressures at the moment. And services started going live in November and are increasing each month in terms of their reach. We've supported that in a range of ways, including funding for implementation support, because we believe it's really often not the tech that's the hard bit, it's the pathways and the change management. And importantly, putting together resources for adopters. So running what we call an innovation collaborative supported by the HSN network to help people share best practice and speed up improvement. As Eric Topol said last year, share more, get smarter, faster is very much the watchword. So for us, a key user, as well as patients and clinicians, are the adopting sites who are putting in these new pathways to try and help avoid wheel reinvention and share resources as much as possible. We've also been doing quite a bit with the care sector, including people probably have seen 11,000 connected iPads going out to care homes to both connect them to things like the summary care record, but also helped residents connect with loved ones. So really happy to talk about that work a bit further as we go through the panel. Thanks.
Thank you, Tara. I think there's a lot there that we'll wind up exploring through the rest of this session, both through the Slido questions that we've had in so far, but also I think there's quite a lot of consistency across quite a lot of what we've heard within the fund around the use of digital technology. Next, I'm going to turn to Marco Francis, who is Technology-Enabled Care Lead for Bristol City Council. Marco, please tell us a little bit about yourself and what you do.
Hello, yes. So my name is Marco Francis. I'm the Technology-Enabled Care Lead for Bristol City Council. My main role is practitioner engagement, where I talk to practitioners about what kind of technology is out there. And I work with a group of people called the Tech Hub, where we get referrals from practitioners, usually hospital-based, to be able to assist the service users or the patients in order to get a piece of technology that would be able to, allow them to be more independent at home, and then happen to have other care packages. This way, we were able to have, instead of just trying to determine what kind of tech would be able to help them, we'll be able to have a discussion with them and have a user personalized technology to be able to assist them in order to being home. So it's not just about figuring out if a person has, like, say, a risk of falls and just determine like what piece of tech is out there. We're able to then have a discussion with them and talk to them what kind of tech would they need to be able to be independent at home.
Thank you very much, Marco. Speaking as someone who's probably spent maybe a bit too much time looking at the statistics around delayed discharges of care within the NHS, there's so many really interesting and innovative things about the work that you're doing that I'm sure we'll explore during the course of the panel here. Next, I'd like to turn to Priti Mehta. She is the Senior Project Manager for Digital Transformation at NHS South Central and West. Priti, please tell us a little bit about yourself and what you do.
Thank you, David. Hello all, my name is Priti Sharma Mehta, and I'm a Senior Project Manager in South Central and West CSU. I work on digital transformation programs and projects in Hampshire and Isle of Wight region. The current program I'm working on is transition of a shared care record called Care and Health Information Exchange, or commonly known as CHI. The Care and Health Information Exchange, or CHI, is a secure web-based system or a tool that aids in remote care provisions by making clinically relevant data available for GP practices, hospitals, community and mental health trusts, social services, and other providers. CHI is one of the oldest and biggest shared care record system. Fun fact, it first came into existence around the same time as when Facebook was launched. So it is really old. It caters for over 2 million patient records, and CHI system, which integrates all these data, essentially underpins the integration of services. It sees close to 10,000 unique users and close to 100,000 patient records exist in a month. So yeah, essentially, it's a tool that aids in remote care of patients and the carer. Thank you.
Thank you, Priti. The ability to exchange information in a powerful and meaningful way is going to be a core underpinning, especially as we move towards population and place-based care within the English healthcare system. So there's a fair few things that we're going to explore, I'm sure, within the CHI project. And finally, I'd like to introduce our last panel member, who is Graham Prestwich. He is the lead for patient and public involvement at the Yorkshire and Humber Academic Health Science Network. Graham, could you tell us a little bit about yourself and what you do?
Thank you, David. I guess first and foremost, I'm a patient with a passion for the value and benefits patients can contribute to improving the outcomes of health and care, when encouraged and with the right support, of course. For the last 8 years, I've become more involved in supporting authentic patient and public involvement. That includes 6 years as a CCG board member and as a member of the board of Health Watch Leeds. I now work part-time, as David's mentioned, at the Yorkshire and Humber Academic Health Science Network, an organisation which has a substantial commitment to supporting digital innovation. Of a particular interest in the more effective and safer use of medicines, and a member of a co-research group working on shared decision-making with patient participation groups in primary care.
So I'd now like to bring us to the sort of discussion part of the session, where we try and explore a bit more about what our panelists do and how it all interconnects across the themes of how we use digital technology more effectively within the health and social care sector. Tara, perhaps if we start with you at the national picture, what are you seeing on the ground in terms of local implementation and how that interconnects with your work across regions?
Well, the way that we've structured this programme is a little bit novel in terms of how a national programme is delivered, because what we asked is regions and ICSs to come up with the areas that they were most interested in scaling in remote monitoring. And many of them, they would look at things, for example, they might have put some technology into 3 or 4 care homes and they'd like to get that to 30. So we went very much where the energy was locally. And I think that may be why we're still getting such great traction with the scheme. But examples would be, there's a really lovely one in Teesside, which is looking at people with serious mental illness who are on antipsychotic medication that can impact your, it can give you cardiac arrhythmia. So that they need to go very regularly into hospital to have ECGs. Now, during the pandemic, that's been really difficult. So a psychiatrist there put a case together for using a tiny little device that can turn your smartphone into an ECG and sending to people's houses a healthcare assistant to go through some physical health checks. The patients have absolutely loved it. You can imagine schlepping into hospital for regular ECGs is really problematic. The clinical staff, I think it's absolutely fantastic. And overall, it's saved both a lot of time and been very reassuring for all concerned. So we've left the brief open such that innovative ideas like that can happen locally. In the Southwest, they're doing some work on physical health checks with people with learning disabilities. But it varies very much from region to region on exactly what they want to do, as long as it was something. Every region is doing something in care homes, which we're delighted about. But they've gone for areas that they've been working on and are seeking to scale, because that's where we think the real magic is. You know, there's been lots of kind of pockets of innovation, but it gets really exciting when patients are really impacting long-term condition pathways. So they're just a few examples of some of the work that we're seeing, but very much led locally. We're providing some investment support for implementation and a way for that community to get together and share ideas. And we're just looking at what a ramped up ambition might be for the year ahead together as well.
Thanks, Tara. I think there's some really interesting stuff there, especially as there's some really interesting questions about how we use digital technology to support people with long-term conditions. Because I think quite a lot of what's happened during the pandemic has been substitutional in a lot of cases rather than transformational. So it's been replacing face-to-face consultations with telephone or video or whatever format it might be, or sharing information that you would normally send in a letter via text. And there's some big questions for ICSs in terms of how they use records and other forms of access to services to support people, as well as information provision. I think before we get into that, though, maybe it's best we take a quick step back, because we've got quite a broad audience in a lot of our events. Priti, I wonder if you could help us out a little bit with an expansion, a bit more of an explanation of what CHAI is, what a healthcare information exchange is, and how that acts as a sort of building block for connecting services together.
Yeah, David, CHAI, I mean, it gets data from almost all GP practices in Hampshire and Isle of Wight, about 180 of those. 4 acute trusts send their data into CHAI. 2 mental health trusts share data, mental health and community trust, 1 treatment center, and 2 councils. So it's a data-rich one-stop window for end users or clinicians. Then this data or information, clinically relevant information for patient, gets accessed by clinicians in these organizations, plus out of our services and ambulance services. So essentially, it provides, it's quite a useful tool. Some of our users, for example, they say that when on weekends, when GP practices are closed and if a patient arrives, they can go into Chai and see what GP encounters have been and what the notes are, or they can learn about that person's medical history. So it's a very well used tool, basically. I mean, it's an ever evolving system from the inception in 2003. As I said, I mean, we've been working with end users, and their feedback has been the key contributor in its development and journey so far. Patient engagement is one of the values of South Central and West CSU. And user engagement is at the heart of everything we do. So we're quite excited to see where Chai is going, where it is transitioning to. Thank you.
Thank you very much, Preeti. I think there's plenty more that we'll get into on the different forms of user engagement as we go forward with the rest of the session. Marco, if I can turn to you next, could you expand with a little bit more detail on what the TECS program looks like within Bristol City Council and some of those steps that you've made towards building user engagement into what you do?
Yeah, of course. Thank you. So a little bit of history. So I work for a team called the Tech Hub in Bristol City Council, and that only started about in May 2020 officially. Before then, how I used to work as practitioners, such as social workers and OTs used to say have a service user, and then they would have a problem and they would try to fix the problem with one piece of tech that they would order. The problem became because there was so much technologies and so much problems that they couldn't really determine what tech could help this service user. So we had this new service where we as a tech hub, our team is a team of 7 individuals. And what we do is instead of trying to just simply have a problem, say someone's at risk of falls and just put a piece of tech in for that one absolute problem, we do everything now discussion based and problem solving based with the service user. That way we're not just seeing a problem going, cool, this is the solution. We're now talking to the service user and asking them, okay, how can tech help you? What can we put into your house that could be able to assist you in order to be more independent at home? This fixes a lot of issues because there might be times where somebody might come in for one problem, but then it turns out that they actually had 5 other issues that they also need addressing. Because now our team is now having a discussion with them, we can now have what I used to call like what I call person-centered approach or user personalized technology, where we're not just trying to simply determine the technology that can help this one problem, but we're trying to determine the technology that can give the person a full package, allow them so that they can be at home with any problem. This way we can talk to them, hear them out, and see what they're at. And because we are hiring a team, which is our team, the Tech Hub, we're hiring a team that specializes in technology. We're able to not only we have the time to look into these technologies, research these technologies, figure out if there's any new type of technology that we can introduce to these individuals. And also try to see if we can do any more trials. This also helps everybody. This helps the practitioner because now the practitioner doesn't have to look into all the billions of pieces of technology that's out there. And it also helps the family members because sometimes technology is not just there to support the service user. It also helps it to support the family because, of course, some families are there to be our carers for some of these family members, for some of these service users. It also helps give peace of mind to everybody. And also, we also spend time to actually show people how to use the technology so that so that there's no issues in the future. But if there is issues, they also have our contact details and they can call us if there's any issues or to help them to see if we can try something new. Because just like one technology might not work for somebody, they'll be able to contact us again and say, hey, this thing isn't working for me. And we can try something else and we can keep on trying something else until we find the best thing that can help for that person.
Thank you very much, Marco. Graham, now that we're getting into the main section of the session, could you tell me what's important to you and your peers as service users? What have you found as sort of top tips or best practice around how to involve people in the design and delivery of virtual care?
Thank you, David. And there's a lot to cover in that question. From what I've observed over the last year or two, I'd like to highlight a few of the more important ones. Firstly, involvement in service design and redesign requires three different types of involvement. Involvement at an individual level, involvement at a community of people with similar needs level, and finally at a population level or population perspective. Involvement needs to cover all three of those in the different ways that best fit those needs. Second is not to make assumptions about me. Assumptions are often wrong and they can be potentially dangerous. I think if people helped themselves, first of all, by asking, what does my patient know that I don't know? That would make a difference to the outcome. And by taking that approach and attitude, helps clinicians ask me the most valuable of questions. Don't forget, of course, that patients already have issues, particularly perhaps most widely documented is the organising and taking of their medicines. And these issues often remain ignored. Diagnostics and monitoring are going to be an additional challenge for many people. Patients know their own experiences and their issues as an individual. Clinicians know the evidence for a population and have clinical skills. And the trick is to being able to effectively blend the two into a personalised diagnosis and a feasible solution. Next one, I guess, for my top tips will be to understand my problem before you present me with a solution. People should be involved in informing a collective understanding of the real and underlying problem. Only then can you involve us in developing solutions to the problem that really counts. And the final step of the three, often missed out, is to involve patients in choosing the measurements of success that really matter, rather than those that are convenient for organisations. I think perhaps some of this is best summed up in the King's Fund report on adoption and spread back in 2018. It talked about supporting the innovation adopters. And when it comes to virtual care, the adopters are very much their patients, families, and carers. And that is where the bulk of the resource and effort needs to land. I remain to be convinced this is actually happening at the moment.
Thank you very much, Graham. I think there's a lot there that overlaps with some of what we've been seeing in some of our recent research, and also some of what we've heard in recent conferences and events as well. I remember talking to my colleague Dan Wellings at our Health and Care Explained event last month. And he was talking about the principles of shifting from doing to listening to patients, and how to really empower people to change the way that you work within the system. And I think those examples around evaluation and measuring outcomes are really interesting. There's plenty of evidence out there that the health and care system and the technology companies, they're producing things like wearable devices or other sensors. They're great at capturing non-subjective data. They're great at capturing how many times something happens, or what your heart rate is, or other bits and pieces, that the bit of tech that you get strapped around your wrist or attached to you in some way is fantastic at measuring, but they do much less about how satisfied you are with your health and well-being as an individual within a scheme. And that's one of the things that we're recommending that people really take a look at if we're going to really spread the adoption of these technologies across the health and social care system. People need to be able to understand, both as patients and as service leaders, what the implications are for people's outcomes from these technologies. Because at the minute, there's quite a big gap in the evidence base.
I think you're absolutely right, David. And that skill and that knowledge to be able to take a number from a machine and then translate it into what activity is most appropriate or what action is most appropriate to take can be a big decision that patients have never been taught to do or work with before. It becomes a medical school 5, 6, 8 years experience piece, not something that you picked up overnight when lockdown came down and you had to change the way you did things. And that is being underestimated at the moment.
I'd now like to start to turn towards the questions that you submitted via Slido. Thanks again for doing so as part of the registration process. And don't forget that that box on the right is still available next to the video where there should be a number of polls, and we should also still be answering your questions live in the session. I think we're going to try and tackle things. There's quite a few questions came through, so we might not be able to address all of them, but I'm going to try and group them together into sort of broad themes that we can discuss here. I think the first one to begin with is digital exclusion. I think this is where quite a lot of the focus of our questions was. It's a huge issue. There's quite a lot that we still don't understand, despite it being such an important topic. And the questions we've had, they cover technical issues, design, bringing together priorities. Maybe we could start with Marco. You were just talking about how you involve service end users in the design of tools. How do you communicate with people during a pandemic, in particular, when they may be at risk of digital exclusion?
Well, because of digital exclusion, obviously not everyone has the piece of technology. So to say do a video call, unfortunately, fortunately, our tech assessors, the people who go out and do the assessments and do the conversation with the service users, are able to do it face to face. That's one of the only ways we can actually, the main way we can do it. That way we don't have to then worry about what kind of technology, what's their internet speeds and what's going on with them. We can just go talk to them individually. Also because we're doing the installations at the same time, so we can go and do the assessments and the installation all in the same day. But for those people who do have the correct equipment, there are times that we can implement whatever tools we need. So maybe Zoom or Microsoft Teams, we're able to help assist those people. But for people who don't have those technologies, we do go face to face and try to have a discussion with them in person.
And Tara, how are you seeing areas build this into what they do, and how is it affecting your strategy and implementation support at the national level?
So just to say, the Tech Hub sounds amazing. Wouldn't it be great if there was one of those in every single part of the country? Because that's exactly practically going about and helping fix this issue for people. So during the pandemic, we saw millions of Britons for the first time ever doing their grocery shopping, banking, and then their healthcare online. It was extraordinary. The vast majority of them finding that experience worked well for them. So we're in a totally different position now from pre-pandemic. Some research that was done before the pandemic, actually also out of the University of Bristol, so we're staying west for this, looked at who was being offered different types of consultations in primary care. And their conclusions were that in the NHS, we've been making a lot of assumptions and guessing what kind of technology people might have at home and also what they might prefer. And I think the time for doing that is really over, and that it's important to make a digital offer to everybody, not make assumptions. They found, particularly in the Bristol research based around age, huge amount of assumptions happening there. We have found similar research recently with looking at who's being offered things like video consultations in the Bangladeshi community in East London, and it's still going on to an extent. But actually, digital offers should be made, and then let's see who wants to best take them up. During the pandemic, when we were looking at virtual wards, for example, would you like the option to be able to leave hospital earlier and put your symptoms in 3 times a day on a very simple app? User interface you mentioned is absolutely critical. The best products have done fantastically involved user design, and they make it so accessible and simple that almost no training is required. And we had, one of our biggest fans was a gentleman of 80 who would much rather have spent 14 days, under his own DV recovering rather than being in hospital. So people are making very practical decisions for themselves. But I think it's a really important message, because particularly video consultations and digitally supported pathways are going to be here to stay, we hope. And we want to make them as attractive as possible to people. So particularly people living with long-term conditions now need to think about their data packages. They need to think about the technology they've got at home if they're to make the most of the healthcare experience. We were able to do some work on this with the telcos during the pandemic, as you mentioned, also clinicians having to overnight work at home. And that included people like radiologists looking at massive file volumes of people with suspected cancer through their home broadband. They helped us enormously speed up access for a number of clinicians to start thinking about these issues, about how do we work in quite a different way. But it is a big issue for the future. But I think not making assumptions is huge. And possibly sometimes people have hidden behind that assumption and that worry that it might not be for everyone and slowed down progress. And I just think of practical ways that we can help make sure people do engage. And the very best products, as I say, really make a point of this. I was just looking recently at some stats from Baby Buddy, which is a great app for pregnancy. And very, very clearly, the highest users are people for whom English is a second language and people with causes of deprivation are watching these videos and finding these resources more useful than the kind of middle class, affluent, white citizen that often other digital products seem to be aiming towards. So the products that make the difference get there and they close the digital divide, which is really encouraging. We just need quite a lot more of those.
Thank you, Tara. I think if I can chip in a couple of thoughts on this as well. There's a lot of overlap between what you and Marco have just outlined with some of what we've seen in recent research. So assumptions, as Tara's just spoken about, from clinicians in terms of what people will or won't be able to work with. When we were doing a piece on the digital transformations that have happened in primary care, which is now available on our website during the course of the pandemic, it was really quite surprising just how many people that we spoke to working in general practice automatically made the assumption that digital exclusion and inequalities was mostly focused an issue around age. Very few people actually brought in socioeconomic status, ethnicity, other factors. And in terms of service design around inequalities, I think we would support the sort of flexibility of approach that we can see in examples like Marco's services in Bristol and some of the services you spoke about there, Tara, where it's not a one doorway entry system where you have to go through online triage, for example, to access your relevant service. And unfortunately, there's still some big questions around that. So a piece that we did for Public Health Wales recently did show that there was a clear advantage in terms of use of new tools if you designed around inequalities, for example, around language or ethnicity and how you delivered them. So enabling things to be delivered via local libraries or other central hubs that you knew that people were able to access technology from. But unfortunately, there was very little information about the additional benefit of that. So we still have big questions about the exact business case and the economic case for spending that extra amount to build in extra languages, extra ways of delivering and presenting information. Graham, if I can turn to you now, how do you think the system can support those who find digital technology very challenging, but still want to engage with digital forms of access to the health and social care system?
Okay, I think there's a couple of things we should bear in mind before we go on to answer that. If we go back to March 2020, the Health Foundation published some work showing that the number of, or the proportion, should I say, of online consultations grew from a steady 15% or so of all consultations. Overnight, this rocketed to nearly 60% of consultations. And this was a similar increase across all age groups. So there's not much time for patients to enable them to readjust to their health and well-being support being delivered in a completely different way. And we're gradually learning how to work with such systems. I think the other important thing is to bear in mind is that we start making assumptions without testing those assumptions to see if they are borne out in reality. From my own experience, the best summary of some of those issues that people have been experiencing was captured in a Healthwatch Leeds report, looking at how people were getting on in the digital era, or the more digital era, with their health and well-being support. And that report highlighted 5 areas where effort needs to be made. Just briefly, those were the money and resources, so that people have the kit and the connectivity to be able to actually run these systems safely and effectively at home. They need training and information about what's available and how to use it. There is a lack of knowledge and know-how, despite so many smartphones being about the place. We also have to think about space, safety, and privacy, because for many people, they live in quite crowded accommodation, and trying to find a safe and quiet place to have private conversation is not actually as easy as some of us might find. We need to think about people's communication preferences. For some, an online approach is very effective. For others, it is just not going to work, and the communication skills needed to make those changes can be acquired perhaps over time and experience, but not instantly. And we need to recognize that in the light of things like the Accessible Information Standard. And finally, the systems need to listen and respond over the long term to what people have to say, and to develop and adapt those systems to meet a variety of needs, so that we're not delivering one solution for everyone, but we're tailoring solutions to individual needs.
Brilliant. Thank you very much, Graham. And now if we turn to the topic of joining up services through technology, we're about to see another big reform in how the English NHS is organised and how it joins up with social care and other organisations as we start to move towards place-based care and integrated care systems. And I think digital technology is going to be a core underpinning for that and the exchange of information. And Priti, perhaps if I could turn to you now, what have you learned through the CHAI work in terms of user engagement on the staff side and learning what people need from the tools that they're going to use when they bring information together?
Yeah, so David, the user engagement has been key contributor in the journey of CHAI. The CCIOs and CIOs of all the major Hampshire and Isle of Wight health and care organization have a seat on both the CHAI program board and STP's digital board, and they feedback what they need, what their priorities are. And that's what we analyze, and then we prioritize how we want to develop CHAI, which then ultimately helps patients and the carers. We also have CHAI Champion Group, which our clinical lead, Dr. Emma Davies, head, where we get feedback from the end users, what they like, what they would like in future. And for the current transition program, where we are transferring our current CHAI system from one platform to another platform, we have a design authority where all the design goes to the design authority. The design authority consists of various end users. They are consultant, clinicians, nurses, paramedics, and they analyze and assess each design element as per their need and feedback on the system. So we couldn't do it without their feedback. The lessons we have learned from the CHAI program about user engagement is that engage your user from the start, not after the system or the process has been implemented. Involve them from the start. We did a user engagement event during the procurement phase and collected their feedback, what they need from their this new integrated system. Listen to friendly users as well as your worst critiques. So there are bound to be users who don't like your system for a variety of reasons, and taking their input on board is equally important, because there may be really good feedback and challenges they are trying to overcome. So we make sure that we go to everybody, not just our friends, but the people who are not using it. I can give you an example of that. When the CHAI program board realized that the system is quite useful, but it's not being used in certain certain acute trust, what could the reason be? And it was identified that nobody wants to remember another username and password. And we implemented single sign-on there. And the usage skyrocketed 400% in that trust. So listening to the users and giving them platform where they can talk about it is very important. Another thing we learned recently in pandemic is don't assume a request made by end user is not important. It might sound really simple thing. For example, one of the trusts requested if we can make phone numbers or mobile phone numbers of patient available in CHAI because their trust system doesn't have their up-to-date contact details. And it was of huge benefit to, we did that immediately, and it was of huge benefit to that trust and ultimately for patients who could then get the calls from their clinicians and get the intervention they required during the pandemic and lockdown. And finally, managing their expectation is also a big part. So as I said, we have a design authority, which I've sometimes called dream authority, where we don't dismiss anything our end users want and ask for as too futuristic or not possible. We log it, we analyze it and prioritize it. But equally, we don't promise anything which we cannot deliver. So these are our lessons from CHAI programs, which I think are useful and universal everywhere. Thank you.
Thank you, Priti. I think there's a tremendous amount of overlap there with what we've seen in terms of good practice around leadership and culture around implementing digital change. In fact, to some of what Tara said during her initial introduction, there's a huge part of embedding digital technology properly within health and social care systems. That is about not seeing it anymore as a problem for the IT team. It's actually about change processes more generally. These are leadership questions fundamental to how we're going to move forwards within the health and social care system. In fact, Tara, if I can turn back to you now, this question of joining up services, interoperability, as some people might have heard the term but not quite be familiar with it, how systems talk to each other and how we build on those for new ways of working and processes. How do you see all that coming together around the idea of place-based care?
So it's absolutely fundamental, and what Priti's been describing it shows the real advantages to populations of that data being able to flow easily. So there's been quite a bit of work during the pandemic about ensuring data's flowing much better between care homes and hospitals. But the longer term piece on this is a piece called Sharing Health Records, which requires all ICSs to get to a minimum level of data sharing by September of this year. So there's quite a lot of work that's happening locally. Obviously, there are many who are in quite advanced stages of data sharing, having been involved previously with things like the LICRA program. But it is the glue that joins good care together. And we also are actively doing work looking at some of the digital health innovators in the space of remote monitoring. It's not a monopoly sector in the way that electronic health records are. There are lots of good mature players, making sure that the data from those solutions links into clinical systems to best effect is work that we are actively engaged in. Many of them do already, but it's making sure that that's the general standard of care across the country. Because without those basics, it's really hard to start getting into really good care, or to get onto the population health benefits that can be seen by stratifying patients, because we know that's essential, for example, for hypertension, home hypertension monitoring, which is an area that actually the UK lags other systems like Germany, where about 70% of people with hypertension will monitor that at home. We're more like 30 to 40% in Britain, and it's not easy to share those results with your doctor. Where we're looking at extending this, of course, practices will need to go after those people with the highest risk scores and hypertension, which often links actually with deprivation as well, and look at how to best support them. So that join up is totally critical. And yes, work that we're actively involved in.
Thank you, Tara. And now if we turn to the topic of bringing patient perspectives as opposed to system and staff ones. Marco, maybe if we could start with you on this, as someone who works pretty much every day with patients directly and their feedback, how do you realign your incentives and your objectives through both the sort of strategic operation of the projects that you work on in your department with what you're hearing from people on the ground?
Well, it's a two-part thing. So with the patients, we do realize that usually patients or service users basically know what they need and they know what they want when it comes to their health. We do take advice from a lot of places, but this is why sometimes it's really good to have like a specialized team that know exactly that they can basically take information from patients, from service users, and then be able to then output with the exact solutions for them. So example, if somebody says, oh, I need something that does this, this, and this, we have a team that can go, okay, they can then translate like a software, like a programming language, or translate to go, oh, you mean you want this thing, and then we'll be able to get it for them. So far, everything we've noticed has been more or less positive. Alongside not only with practitioners but with also service users, and obviously we're a new team, so we do take feedback. We take all information from all places to find a way so we can grow our team. That way we'll be able to look into more technology, look into more things that can help assist people long term, and to be able to widen our catalog.
And Marco, I assume there's quite a lot of overlap with what Priti talked about with clinician and other staff service user engagement, in terms of no query is too small or utterly invaluable. You can learn something from everything, but you can't deliver everything, so don't make promises that are unrealistic, and have a more equal peer-to-peer relationship that's fair to both you as a provider and service users as well in that dialogue.
Yeah, of course. So like I always say that there's no such thing as a stupid question or stupid query or anything like that. So what we do is we take advice from all sections. So even if a practitioner gives us something small and says, oh, is there something like this that exists? We always go to them. Yeah, we can look into it for you. So we don't look at them and go, oh, that doesn't exist. We say, yeah, we'll look into it and see what we can do. And of course, if it's not possible, then we find an alternative that's similar to what they request. That way we can at least, and then what I found out sometimes we hear a suggestion and we look into it and we realize that's actually a better solution than we could even think of. So sometimes talking to practitioners, talking to all corners of the from patients or practitioners, able to help us to grow, help us to actually understand what the service user actually does need in their day-to-day life.
Tara, if I can quickly turn to you on this idea of offering people different entry points and allowing accessibility. It's not that we're going to wind up with a national one-size-fits-all system, is it? It's more about how local systems develop their own offerings and what works for their local populations.
Yes, I think that's right. I think that across certain clinical specialties, there has been a lot of learning. We've recently published a series of digital playbooks, kind of crystallizing some of the best examples of how digital can really change a pathway. So I think there could be areas that people get consensus on, that actually it's a better way of delivering care routinely. But it would never be that digital is the only option for people. I mean, at the moment, I think we're in some ways quite at the other end of that. You know, the NHS spends at least £20 million on sending letters by second-class post to addresses that people may or may not live at. There's not been an option in many places until very recently to have those things emailed. So there's a considerable way to go. But yes, in the main, what we're doing is going with the grain of the work that's happening and building on that as rapidly as possible. And we're actually being informed by a lot of the evidence, including the excellent report on adoption and spread of innovation by the King's Fund a couple of years ago, which said the way that you best encourage spread is not to obsess about the inventors, but actually support the adopters. So that's the model that we are trying in this work.
Thank you very much, Tara. And finally, Graham, if I can turn to you, how can we engage patients and service users in designing a virtual care offer going forward?
Okay, I'd just like to make a few key points on this. Again, a big subject about involvement generally. But firstly, I think it's important to recognise and indeed accept that it is about designing the best care offer, and that virtual care is one of the options, but not the only option. We need to design options that best suit people rather than systems. We need to learn how to tailor the solution to the real problem. For example, diagnosing a swelling in the abdomen probably favours a physical examination rather than a phone call, I would have thought. We need to provide clear and accessible information in different formats so that people with additional and changing needs can make an informed choice. Involving users in this work and learn how to do it once and share across communities would be a much more cost-effective way of sharing that knowledge. I think it's important to focus on benefits and advantages for patients, in particular around the quality of care and how that may be improved and indeed much easier to gain good quality care more quickly. My own experience is that a phone call in some instances, but not all, was far quicker and more convenient, and I reached a good outcome. Finally, we mustn't overlook the existence of GP patient participation groups, a group of people already there and willing and able to be involved in learning how to share the virtual opportunities more effectively within and without the practice.
I'd like now to bring us towards the end of the session. If I could turn to each of our speakers in turn and ask for their reflections on what we've talked about here today. Tara, perhaps if I could start with you.
So I've really enjoyed today's discussion and hearing from the perspectives of other panelists. And I think the thought I'm left with is how we help best support the population of this country moving towards using these tools in different ways. We've been running a campaign called Health at Home, which has been seeking to do that. And things like a video on how to do a video consultation with your doctor have had over 7 million views. It shows the interest and appetite, I think, that's out there for learning. And we also asked YouTube to promote it, which really helped. We're getting 60 million hits a month on the NHS main website. So people are looking for ways to be supported on digital care. And I think that's something that we, working with charities and other organisations, will need to do to make this a genuinely better alternative to the face-to-face care that people have experienced in the past.
Thank you, Tara. And Priti, if we could hear your thoughts, please.
Thank you to King's Fund and South Central and West CSU for providing this opportunity to share our thoughts on such an important and pertinent topic. I learned a lot from my fellow panelists, and I echo what Marco and Tara said, that respect your users and don't assume for them. Ultimately, patient is first and patient knows best. That's my learning from today's discussion. Thank you very much.
And Marco, your reflections.
Yeah, really thanks for joining this session at this time. And I want to mention that, just like everyone's kind of said, that it's always good to learn. It's always good to try to advance your skills, and also understand that technology is rising, technology is getting better, and it is getting maybe more complicated. And if we all come together and we have a conversation, we can all learn from each other. And we think that things can be improved very rapidly, and it can be there to not only help the practitioners, but also help even the practitioners in the field, supporting and the carers supporting these practitioners. These service users.
Thank you very much, Marco. Finally, Graham, if we could have your thoughts, please, on what you've heard today.
Thank you, David. My impression is that there's a strong desire to involve patients, families, and carers. And there are some great examples. But we must remember that authentic patient involvement has to move on from good exemplars to widespread business as usual before we can genuinely show that we are delivering a patient-centered health and care system. I think there are real and well-evidenced concerns about the negative impact of innovation on inequalities in outcomes. And we need to better understand intersectionality as the route to narrowing that gap. And finally, I'd just like to say it's been a privilege to join the speakers today and participate in this meeting. And I'd like to thank the King's Fund for inviting me. Thank you.
So once again, thank you very much to our panel and to you as well for watching. Please do share the link with colleagues who can watch on demand as well. There's going to be a feedback button appearing at the bottom of the screen, asking you for your feedback. We really value it. It informs what we do and how we do it. So it does have an effect going forward. As well as an email link that might wind up in your inbox shortly. You'll also be able to feedback there. And finally, I'd like to thank our sponsor, South Central and West, for helping us to put this all together. And I hope you have a good day. Thank you.